Okay, again, my name is David Kanashko. I'm a chiropractor and the Director of Education, Research, Training, and Chief Bottle Washer here at Meditech International in Toronto. We manufacture Class 3B and LED photobiomodulation devices. For those of you out there that are listening and still think that this is only laser therapy, there's a really great editorial on the definition of photobiomodulation and the different sources of light that you can use to achieve that. So it's not only a laser that can achieve that, but even LEDs or even other sources of light. And this editorial is really good. If you're interested in seeing that editorial or reading it, just send me an email. At the end of this webinar, I'll have my email and you can send me a request. So today's webinar is on nerve injury and repair. I think it's a really fascinating topic. I do get a lot of questions pertaining to if laser therapy or photobiomodulation, here I'm saying laser therapy, photobiomodulation can actually help with nerve repair. And certainly in most cases it can. So I want to run you through firstly a brief overview of the anatomy and the injury and repair process of nerves, just so we can refresh our memories. And then talk a bit specifically about how low-level light, or of course laser or photobiomodulation, helps to repair the damaged nerves. And then I'll bring up a few research papers that talk about the aspect of nerve repair, both randomized control trial and in vitro experiments as well. I'm also going to just touch on the topic of how PBMT or LLOT can block nerve pain. Not so much repair it, this reference. I'm talking more about how you can achieve analgesia or pain relief. I just thought it was appropriate to talk about it since we're talking about nerves as well. And then lastly, I'll present a couple of case studies from our archives here at Meditech in Toronto. And I'll have time at the end for a Q&A. Okay, so you all recall the basic structure of a nerve. This entire large sort of cylindrical picture here is a cross-section of a nerve, and the outer covering of the fascial covering is referred to as the epineurium, so that's the outermost covering. Of course, that contains blood vessels, arterioles, capillaries, and veins. So critical for helping with nutrition for the nerve itself. Then, of course, there's bundles of nerves, and these bundles are referred to have an outer covering, and that outer covering is called the perineurium. And then the endoneurium, which is the most inner lining of a nerve, a specific axon, in fact, is an endoneurium. So again, we're going from epineurium, which is the outer covering of the entire peripheral nerve, to the perineurium, which surrounds one fascicle or a bundle of smaller nerves, and then the endoneurium, that is the covering around one specific axon. And remember that peripherally, anyhow, these axons are myelinated by Schwann cells, and of course that's critical for the appropriate transmission and conduction of the nerve impulse. Schwann cells are critical. We'll talk a bit about Schwann cells later on, but they're critical for the repair of damaged nerves as well. Going back to the 1940s is when nerve injury were first classified. The classical classification was by Seddon. Neuropraxia, which is basically a mild injury or first degree, which is a conduction block and some form of demyelination. Then there was a reference to axonomatomesis, which is more of a secondary degree axonal loss, more like a compression kind of thing. And then more seriously is a neurotomesis, which is basically third, fourth, and fifth degrees as they were described by Sunderland in the 1950s. And the fifth degree being complete disruption of the epineurium, meaning that it's severed. So you go from a pressure injury to a crushing injury to a partial severing to complete severing of a nerve. Those are really the classifications of how nerves are injured. Right. So neuropraxia, which I mentioned, is more of a mild form of injury. This is where a nerve is compressed. It can even be due to stretching. There's a condition you may have heard of called Saturday night palsy, which is kind of funny when I learned about it. It references when you're out with your friends having a few too many, like Mike Sider is known to do. And then you fall into a ditch. And as you fall into that ditch, you outstretch your arm and you stretch the nerves of the neck and the thoracic outlet. So that would be a case of neuropraxia. Fortunately for Mike, your prognosis is quite good. Usually there is full recovery. It probably takes weeks as opposed to days. And oftentimes, or usually, you don't require surgery. The next level is more of a crush or a displaced, or it can be caused by displaced fracture, axonomatemesis. This is a disrupted axon. The endoneurium, remember that's the most inner lining of an axon, is intact. There will be Wallerian degeneration taking place. That usually starts after 1 to 2 weeks. And again, depending on the extent of this type of crush injury, the prognosis is fairly good. Remember that nerves heal very slowly, only about 1 millimeter a day. So depending on the length of the nerve, you can imagine if this is a nerve that goes all the way down to your leg, and it's crushed somewhere along the line, it is going to take a really long time for that nerve to actually heal. And then, of course, a complete laceration or even partial laceration, neurotomesis, is oftentimes much more serious, usually requires surgery to put the nerves closer in proximal position for repair. The prognosis can in fact be quite good, but depending on the surgery, depending on the extent of the laceration and so forth, in fact, it may be a very poor prognosis. We all know people that have gone in for surgery that have had a scalpel blade go through nerves, and they're left with permanent sensory loss or sometimes even motor loss because that was never detected during the surgery. So a review of Wallerian degeneration. Recall that there's going to be the initial insult or injury to the axon. This will lead to a degeneration of that axon distal to the injury. And what happens is you'll start to get an accumulation of macrophages. Now, this is important because with respect to low-level laser therapy, we know that the numbers of macrophages and their activity is known to be increased when exposed to light, specifically red and near-infrared light. So if you can get to a fresh injury, you certainly will expedite and accelerate the healing process because of the increased macrophage activity. During this time, you'll have growth factors being released, and you'll start to get proliferation of Schwann cells in preparation for the regeneration phase, where they start to surround the axon as it regrows, remyelinate it, and reform the connection, in this case, the terminal connection to the actual muscle fiber itself. So that's Wallerian degeneration. A little bit more in depth as far as the injury repair process. When the axon is actually separated from the body, there is a degeneration of the axon. It will stop at the synapse and it will not travel to the next neuron. So again, as I explained, you have an influx of macrophages. These macrophages go in, they help to dispose of and undergo phagocytosis and get rid of all the crap and the injured axon and the myelin sheath that needs to be cleared out in preparation for the regeneration. The peripheral nerves have these Schwann cells obviously in and around the periphery. And they, of course, help in this regeneration phase. They grow into the cut area and actually sort of glue the two ends that are separated. Excuse me. That's why it's so important in order for the proximation of these nerves for them to heal faster. Schwann cells grow into the cut area and they actually help bring these two ends closer together. The entire axonal material is phagocytized from the site of the injury all the way to the end plate at the muscle fiber. So a new generated axon will sprout and grow to reestablish the connection to that end plate, in this case at the muscle fiber. So really what's going on there, there's a synthesis of growth promoting molecules are secreted. And again, we know from a lot of in vitro experimentation with photobiomodulation that it facilitates the release of these growth promoting factors. This will lead to a greater efficiency of Schwann cell proliferation. Remember that it's distally you will find the Schwann cells proliferate and the axon sprouts. So they actually sort of form out like finger-like growths, and then they slowly advance. And as they advance, the axons will sprout, and Schwann cells basically act as a guide, and these sprouts, as I mentioned, advance quite slowly, at most 1 millimeter per day. So eventually this will help for the regeneration and eventual remyelination. So there are quite a few factors that affect the variability of nerve recovery. Obviously, the younger you are, the better hope that you have of a more complete or a better prognosis. The more distal the injury, the poorer the prognosis. If there's no significant delay in the repair process. Obviously, sharp cuts are better than crush injuries. Sharp cuts could be approximated better than crush injuries. If the blood vessels are intact or mostly intact, obviously that would mean for a better prognosis. And obviously, if there's favorable orientation of the nerves during the epineural repair process, that in fact also will be quite critical. Can everyone hear me? I just got a little note saying that I had a disruption in my broadcast here. Just type in if you could that you can still hear me. I'd appreciate that. I'll continue on anyhow. All right. So how does laser therapy help? Well, many of you have seen this diagram before. It talks about all the ways in which photobiomodulation can help with different cell types. Specifically, when we talk about nerve regeneration, there are specific effects that have been known to affect them. Great, everyone can hear me? That's good. So let's talk about that. So first of all, we need to understand is we need to get the light to the target injured nerve tissue. If you can't get direct light to the affected nerve, then it makes it more challenging to really have a great effect with photobiomodulation. So you do really have to think about the depth of where the nerve damage is and whether or not you can get direct light to it. We know that low-level laser therapy improves nerve cell metabolism. We've talked a lot about the electron transport chain and the increase in ATP. And of course, I mentioned about macrophages. It increases the number of active macrophages and their activity. So this is critical in the repair process of nerves. It can induce axon sprouting and Schwann cell proliferation. I have a research paper to discuss that. And it decreases post-traumatic retrograde degeneration. We also know that it limits scar tissue formation. This is really important because the more scar tissue you have in the way, the less likely you will have for a complete repair of the damaged nerve. And overall, it's going to improve the recovery and functional activity of injured peripheral nerves. And again, I have a nice paper to show you that. So let's talk about Dr. Shimon Rashkind for a moment. He's a specialist in neurosurgery and microsurgery in Tel Aviv in Israel. A well-known researcher in photobiomodulation, specifically when it comes to nerves. He's a well-known publisher. If you go to PubMed and search his name, you will find lots of great articles. In this particular one, in his paper, he states that laser phototherapy accelerates and enhances axonal growth and regeneration after injury or a reconstructive peripheral nerve procedure. Laser activation of nerve cells, their growth, and axonal sprouting can be considered as a potential treatment of neuronal injury. And this is going back 10 years now. So one of his papers where he actually showed when you stimulate a nerve with light, then it actually increases the migration and fiber sprouting of the neurons. So they develop these large cell neurons with dense branched interconnected networks of neuronal fibers when exposed to low-level laser therapy. So you can see here in the control neuron and then the one that was exposed to low-level laser therapy, you can see all these branches coming out, these other axons, and again, it's affecting and creating more growth of that neuron. Another paper, this one was a control trial, and it was a trial anyhow. They had 18 patients with diagnosis of traumatic peripheral nerve injury that had occurred at least 6 months prior to inclusion. They were using near infrared, so 780 nanometers, which is the sort of the lower end point of the wavelength that you'd want to use. Notice they're using 250 milliwatts continuous wave. They also did a placebo as well. And they treated for 21 consecutive days, applied directly to the skin or transcutaneously. They treated both the spinal cord area. The laser was performed again on the skin, above the projection and corresponding segments of the spinal cord, which was divided into 2 intervertebral levels. Each level they treated for quite a long time. It was 60 minutes a day. Some of you out there that use BioFlex can relate to how your treatment times are quite long. And especially when it comes to nerve repair, that is probably really important. They also treated the direct peripheral nerve area that was injured, again, directly on the skin, above the projection of the injured nerve. And it was divided into 3 parts, either proximal, the injured area, and distal. Again, 60 minutes a day. So a total of 180 minutes a day in those 3 areas, showing you the energy density that they used. So from this paper, they said the analysis of motor function during the 6-month follow-up period compared to the baseline showed statistically significant improvement in the laser-treated group compared to the placebo. And they found there was no statistically significant difference found in the sensory function. I do have a brief comment about that. We know that repairing sensory nerves is more challenging. So the afferent nerves is quite complicated, and I'm not an expert in it, but I do know that the repair process for the afferent nerves is more challenging based on issues that occur at the spinal cord level due to inhibitory mediators. So electrophysiological analysis showed statistically improvement in the recruitment of voluntary muscle activity in the laser irradiated group compared to the placebo group. They concluded, and this is Roshkind saying, that this pilot study suggests that in patients with long-term peripheral nerve injury, non-invasive near-infrared laser phototherapy can progressively improve nerve function, which can lead to significant functional recovery. Okay, so I'd like to just talk very briefly about nerve-induced analgesia. And this is referencing using a very high irradiance or power density. Look how high I'm referring to. It's 300 milliwatts per centimeter squared. Okay, so that's a lot of energy in a small area. This light can be absorbed by pain receptors or nociceptors and can actually exert an inhibitory effect on the pain fibers, both the A and the unmyelinated C pain fibers. It slows the conduction velocity, reduces the amplitude of the compound APs or action potentials, and can actually suppress neurogenic inflammation. Roberta Chow is one of the leading researchers in this field, and she continues to do research in this field and has suggested that LLT blocks anterior-grade transport of ATP-rich mitochondria in the dorsal root ganglions. So recall if you use our equipment, you'll know that we have 2 types of laser probes. We have an LDI infrared, 200 milliwatts. Its power density is 1,800 milliwatts per centimeter squared at 100%. So you can see it's more than powerful enough to actually achieve this analgesia directly on the nerve. And in fact, even our red laser probe that's going to target more superficial nerves, especially the C fibers, the nociceptors, again, it has quite a bit of energy density that can provide that type of analgesia. Here's a video showing you axonal flow of mitochondria in a normal axon. So what you're seeing here, maybe I'll repeat it, is the actual movement of mitochondria down the axon. So mitochondria need to flow to provide energy all the way down the length of the axon. So whether the axon is 1 centimeter or 200 centimeters long or longer, if you happen to be Raptors basketball player or Embiid from the 76ers, who will for sure lose tonight. Lots of long nerves in those bodies. All right, so what happens is you get these varicosities that result from the inhibitive effect and result in the block of anterograde transport of these ATP-rich mitochondria. This interruption of fast axonal flow reduces the availability of ATP necessary for what's referred to as microtubular polymerization and maintenance of resting potential. I'm not an expert in that, so I will not comment. This effect is, however, completely reversible. So what you will achieve is nice pain control for maybe a day or two. It doesn't have to do with long-term inflammatory reduction or long-term healing reduction. What it does, however, provide is a patient with some nice temporary pain relief. From one of Chow's papers, this is showing you a normal axon. And then what happens is 30 seconds after that axon, that live axon, by the way, was treated with 30 seconds of 830 nanometers continuous wave light, you can see the development of the varicosity. Okay, so the question is, how can we possibly reach these dorsal root ganglions? Remember that these dorsal root ganglions are quite deep. This, of course, is a cross-sectional view of a vertebrae showing you the spinal cord. Recall where the bottom of the picture, it would be posterior, and of course the vertebral body being anterior. Dorsal root ganglion being in the intervertebral foramen, and as it exits, this is the area that you're trying to target with light. Okay, so here's a dorsal root ganglion. Here's the facet area. Notice that if you try to throw in light or apply light just lateral to the spinous process over the erector spinae in this area, general area here, you will be hitting a lot of the bone. You'll be hitting the facet joints, the pedicles, and so forth. So it makes it more challenging. The approach is to come off laterally to the facet joint around the lateral edge or the central lateral edge of the erector spinae, push in and direct your light to where you feel that dorsal root ganglion is. Okay, so that's really important if you're trying to get light into that specific area. So you need to apply firm pressure with the laser probe at the lateral margin, and it needs to be angled in towards those facet joints. So again, you want to make sure that you're going to treat the spinal nerves as well. So in the case of, say, the cervical spine, recall where those spinal roots are exiting, and you want to apply that laser probe in that general area as well to help get a nice photobiomodulation effect. Remember that depending on the size of the neck that you're treating, you're going to have to hold that laser probe for a certain period of time in order to get enough light at that depth to be effective, right? So this is referred to as the effective depth of penetration, where the longer you hold the light source, the greater the effective depth of penetration. Of course, light can only go so deep, and that varies depending on the density of the tissue. Okay, let's wrap things up with a couple of case studies. In this particular case of carpal tunnel syndrome, typical signs and symptoms for a 54-year-old female patient. There is wearing a splint at night, using some Advil. Signs and symptoms: there was no wasting, there was a decreased sensation, and we noticed decreased grip strength. There was a positive Phelan's test, and there was painful areas on the left forearm muscles as well. We do a neurometrics EMG here in our clinic, so we can actually measure these intervals. It takes the conduction time between certain points along the nerve. So anything greater than 4 milliseconds as far as latency means that there's a indication of carpal tunnel syndrome. This patient came in at 5.29, which would have been a moderate latency, so it came back as there is a moderate left median neuropathy at that area. we started to engage treatment directly over the wrist. We did one right along, adjacent to the wrist, and then we did one cross-sectional wrapped around the wrist as well too, so directly over the carpal tunnel. You can see the protocol here. It was continuous wave for the red, and we did 20/70, so a fairly high duty cycle, but a fairly low frequency, 6 minutes for each placement. And then we used both laser probes, initially at 42% of the 200 milliwatts of LDI 200, 100 milliwatts for the red, and again, anywhere from 5 to 7 minutes at each point. We progressed up to 80% duty cycle by treatment 6, slightly increased the frequency, and we altered the red as well, even though it's still a very high duty cycle at 90, which would mean that you're getting almost all the light in there. We start pulsing that out. We find 100 cycles per second is a good way to overcome adaptiveness of the tissues. Again, same time frame. We also increased the intensity or the power of the probe up to 200 now of the LDI 200. By the time we went to the 9th treatment, you can see that we just started to play around with the frequency a little bit for the dual infrared array. And by the time we got to the 15th treatment, we're now down to 1 time a week for the last 3 or 4 weeks, and we ramped up the frequency. Again, increasing the frequency helps to overcome adaptation and plateaus in the response to the light. So after the 15 treatments, we redid the EMG, and we found that the latency was back to normal at 4.4. So in fact, we were able to achieve a nice healing effect on the median nerve. So some tips as far as carpal tunnel syndrome goes. Obviously, if there's muscle wasting, it's more advanced. Definitely a poor prognosis in that case. Remember, you're looking at all sorts of outcome measures, not just EMG. You're looking at what they can do, range of motion, the grip strength, all those different things. And of course, adding manual therapies, ART, or other techniques where appropriate also makes sense. Remember, also look for other possible sites of entrapment, whether at the elbow or at the neck as well. Last case was a right hand open crush injury. I treated this person myself. They came in with a severe crush injury and a partial severing of the nerve injury. So they were progressing quite slowly with respect to their edema, the pain, and sensory loss. They did have physical therapy shortly after the surgery. They had a release, carpal tunnel syndrome release surgery as well as the initial surgery. And they tried to reposition the traumatic neuroma that was appearing on the palmar aspect of the cutaneous branch to the median and ulnar nerves. Upon presentation, there was a significant joint pain, decreased sensation, especially around the hypothenar eminence and fifth finger, significant edema, and lots of adhesions as one would expect. Grip strength was very weak in the right hand. Pay attention to that. That was 25 pounds on the affected side. Here's the initial presentation following the surgery and the carpal tunnel release. This was how they presented initially. So, fairly decent healing at the cutaneous area, but the issue, of course, lied deeper at that. Just a review. Remember that the median nerve lies deep to the carpal tunnel, so the crushing and laceration was right through the carpal tunnel, and also injured the ulnar nerve. So we tackled this. Initially at 20/60. As far as the infrared goes, we did 4 placements. Both the palmar and the dorsal aspect of the hand was treated, and then we sandwich-like wrapped the array on both medial and lateral aspect in order to get really good coverage around the wrist. By treatment 4, we were increasing the frequency and the duty cycle of the dual array. By treatments 8 to 15, again, increasing the frequency, keeping the duty cycle at about the same for the near infrared, but now again modulating the dual red, and taking the laser probe up to 100%. 9 minutes was quite a long treatment time, but remember, 9 minutes had to cover that large area of the hand and the wrist that was affected. The patient responded quite well when they were released from care. Their grip strength was up to close to 60 pounds, still not 100%, but a significant improvement. They also had subjective improvement in sensation. That was the hardest thing to try and restore in this patient. Edema went from moderate to mild. Pain lowered from 10 down to 6. And overall, there was a 30 to 40% improvement in the function and pain. Unfortunately, we weren't able to treat past 14 or 15 sessions due to issues with funding for the patient. Their pain in the metacarpal phalangeal joint also resolved, and they went back to work at modified duties. All right, so awesome. We're all done. I will take questions. Just a reminder that we do have a couple trainings coming up in June. 14th, 15th here in Toronto, and July 12th and 13th. If you've never been to one of our trainings, regardless of the kind of equipment that you have, I think you'd really benefit from 2 days of our laser certification training. So I'm going to take some questions now, and let's see where we're at with questions here. I have one question from Sandy. Does this repair process apply to neurons in the brain as well? It's a slightly different process because there's no Wallerian degeneration there, but it's similar in that it helps to initiate mediators that help with the repair process. But because it's not direct light usually, or very minimal direct light, you're counting on having that effect mediated through the blood. So yes, it can be helpful, but it's not as effective as, say, a peripheral nerve where you can get directly light to that lesion. So a question from Mike about the application of diabetic neuropathy. Mike, you must have missed my webinar solely on diabetic neuropathy. So shame on you. Please go to our support page, log in, and you'll find it there. If not, let me know and I'll direct you where that is. Hi, Jeff from the United States out in Colorado. I know Jeff quite well. He asked me the occasional question. Jeff did mention, he says that I'm not an expert, but can you say any more about sensory nerve repair? This is in regards to the patient that he had mentioned to me earlier. Yeah, I was just reading in preparation for this webinar today about the issues with afferent nerves, the sensory nerves, and how they repair at the spinal cord level. And apparently there's some inhibitory mediators that really affect how they get healed. To be honest, I'm going to have to read more about that because it's been a while, and again, I'm not overly familiar with that. So, Jeff, let me do a bit more reading, and I'll email you back on that. Hi, Patricia. She has a question. Rather than injury from surgery, is the same therapeutic nerve result possible for damage from herpes zoster? I think with herpes zoster, you're dealing more with the live active virus that gets activated in the nerve. So it's not so much, that nerve will be inflamed and it will be problematic, but it's not damaged in the same way. We know that laser therapy can definitely help herpes zoster. Dr. Kahn has made it a career of his treating herpes zoster here in the clinic with really good results. So we definitely know that it can be very beneficial. How is red light beneficial to carpal tunnel syndrome, Eliza? Good question. The red light really is more for pain control because it really does help with affecting the nociceptors on the superficial aspect around that carpal tunnel, around the hand in this case. So the goal with the red light isn't so much to treat the deeper structures, but more to help modulate pain. Can you address phantom pain from amputation? Wow, that's a really good question. I wish I could. I think I saw one paper on that, Leonard Vincent. If you want to email me, let me see if I can dig that up and try and get that out to you. I recall reading something about it, but it's been a while. When is it too long after injury to attempt treatment following nerve injury? I don't know. That's a good question. I think that that probably it's longer than you think. We have treated patients that have had years of difficulties with nerve healing, and we've had some improvement. So really, I think that regardless of the time frame, you may still be able to help. It's just that the prognosis is that much poorer. So, yeah. Anyway, All right, so that's the webinar for today. Again, thanks all for joining me today. This webinar will be edited and will be sent out in an email in a week or so if you want to watch again or if you had to tune out or what have you. And again, check out the website again for the upcoming webinars. Remember that my email is david@bioflexlaser.com. So feel free to email me if you wish. And I do encourage you, if you haven't been to one of our laser therapy trainings, you can get to Toronto. It's really quite a pleasant place by the time July and August roll around. Then we welcome you to come out here. All right, take care, everyone. Bye.